And for those of you who are joining as usual, please put your name and institution in the chat for our roll call and attendance. Welcome to our 13th webinar. This is our Maternal Equity Bundle Year in Review. Thank you. For those of you just joining, please put your name in the chat. Welcome. Keep yourself muted as usual. Feel free to type in questions in the chat during this. We will be going over the results of the year for the Penquin Maternal Equity Bundle. And so looking forward to having many of you ask questions and seek for understanding related to the data we'll show. These sessions, as usual, are recorded. You can find them on our webpage, our new beautiful webpage, penquinma.org. Thank you to our staff, Kaylee, Caroline, Kristen, for support and making sure that that webpage is user-friendly and easy to find things. And with that, we have our page for the Penquin Maternal Equity Bundle with recordings for CME available. That ends, and CEU available, and that ends this year. I have to ask Allison, what is the age for being too old to dress up? I even have my costume this year. All right, we'll go to
14 and 16.
Oh, yeah, that's that middle age, right? Yeah. Just wanted to share, I have my Barbie jumper with my pink sunglasses ready for Halloween. I'm so excited about my costume. Welcome. For those of you who are just joining, please type your name and your organization into the chat. And we'll go to the next slide and get started. Oh, actually, let's go back one more just for those who just jumped on. We have a question for everybody in the chat. Please share, what will you or your child be for Halloween, and what is your favorite Halloween movie? I actually don't think I have a favorite Halloween movie. How about you, Kaylee?
I actually love to watch Clue at Halloween.
Yeah.
That's probably my favorite. Spooky and funny.
You actually remind me of Bette Midler and Wicked, and how they had the 20-year remake. Oh my gosh, that was the best. I loved it. And it was in Salem. Oh, I love it. Dr. Larson will have a witch and a unicorn with Hocus. Oh, that's what it's called. Yeah, Hocus Pocus is not Wicked. Yeah, right. Hocus Pocus is the name of that movie.
Yeah.
Nice. All right. Well, let's go ahead and dive in, guys. For those who are just joining, please put your name and your institution in the chat. We'll go to the next slide and we'll do some welcomes and participation celebrations, and then we'll go into the data. So I'll turn it over to Kaylee.
All right. Thank you, Audra. And yes, everyone, please keep putting in what you or your child will be for Halloween this year, or if your kids are sadly too old to dress up, let us know your favorite Halloween movie. All right. So we just wanted to take a few moments before we jump into the meat of today's webinar to acknowledge everyone who brought us to the end of year one of the Equity Bundle. Of course, we acknowledge them always, but want to give another shout out today to the Equity Bundle Work Group, who has met with us pretty much monthly over the last year and before to help us really put together this bundle, shape the webinar series, continually provide feedback on components of the bundle, data collection. So we would not be here without all of these folks. And continuing on, this slide should look familiar. Again, these are our participating hospitals in the Equity Bundle. We had 22 of them spread out all over the state. And we are so excited to continue working with these hospitals. And if you're from a hospital not on this list, we hope you will formally join us as we enter year two. In addition to the hospitals on the previous slide, we also had 43 additional partner hospitals and organizations join our webinars over the last year. So this includes other MA hospitals, other Massachusetts institutions. We've had folks join us from as far as Colorado, Illinois, Maine, and New York. Lots of representation here on this list. So just thank you to everybody for coming to hear what we had to say and to continue learning with us as we continue on our Massachusetts journey. So also want to give a shout out to our 17 hospital data submitters over the last year. So 17 of the 22 hospitals participating were able to submit data. On average, we had 15 equity bundle data submissions per month, which is amazing. We know that the equity bundle or the AIM monthly data survey is not a short survey. It takes time, it takes digging into your records. And so just want to say thank you all so much for committing to this every month. And it has largely made what you'll see today in Dr. Meadows' presentation possible. So thank you. In addition, we had our equity bundle kickoff last year, as well as the previous 12 months of webinars. Our total registrants as of last month across the first year of the bundle was 278, which was amazing. And we had on average 60 attendees per webinar, which I think is the most out of any Pinkwin bundle to date. So we're just so excited to keep spreading our wisdom and our collaboration far and wide to so many people. And speaking of people, we wanted to give special shout outs to the folks listed on this slide. These individuals representing Massachusetts hospitals attended or watched 50% or more of our webinars over the last year. So just thank you all for taking an hour out of your month each month to join us and be here with us and contribute. My last few slides are going to be acknowledging hospital teams. So shout out to Holy Family, Salem Hospital, South Coast Health, and Signature Healthcare at Brockton for, as a team, joining 50% or more of our webinars. Again, it's an hour out of your month, and we're glad you choose to spend it with us. Now, for the next couple slides, you all may remember seeing some participation reports from me and Caroline in August and September. And so we just want to acknowledge those teams who, in their combined efforts for data collection and webinar attendance. So congratulations to our red ribbon hospitals who had an average between 51 and 75% across webinars attended and data submitted. So thank you so much to Mass General, Mount Auburn, and UMass. And then finally, our blue ribbon hospitals, so an average of 76 to 100%. This great group here, just going to shout you all out: Anna Jakes, Cambridge Health Alliance, Bay State, Emerson, Lowell General, BIDMC, St. Vincent, Martha's Vineyard, Beverly Hospital, Mercy Medical Center, Brigham and Women's, Boston Medical Center, Tufts, and Winchester. Thank you all so much for your continued participation in this bundle and for making it what it is. We wouldn't be here without you as well. And so before I turn it over to Dr. Meadows, and I'm sure she's going to echo this sentiment, your time is valuable. So I've already said it before, it takes time to submit the AIM monthly surveys. It takes time to attend our webinars. It takes even more time to put, the actions, the structures, the processes we've described on these webinars into practice at your hospital. All of that takes time. You all are valuable, and we appreciate every minute that you've participated in this bundle. So thank you.
Thank you so much. That was terrific, Kaylee. And thank you so much to all the teams on the call and all the teams that have joined the calls in the past and moving forward, the teams that will continue to join. We often have such a robust showing at our summit, somewhere on the order of 300 to 400. And so we just want to always show our appreciation for this involvement. And more so than just you voting with your feet and coming to a lot of the activities and events, It's also how, thank you for the engagement, because as I'm going to show in just a moment, your engagement has improved outcomes. It has saved lives that we won't be able to count or know, but just know that when we see improvements in these best practices, it means that we're improving experiences and we're improving outcomes and we're saving lives as well. So let's dive right on in. First, I wanted to start with what were our measures for this PenQuin Maternal Equity Bundle. We kicked off this bundle, you can go to the next slide, in September 2022, and we talked to you about 10 measures. You'll see 9 here, the 10th being your SMM, so those severe maternal morbidity outcomes. With that, we had structure measures that focused on a few things: the formal equity team, communicating your goals, having a system and for a data dashboard to collect data, to disaggregate data, and to monitor data. And also making sure that your hospital addressed patient-reported experience measure. And we're going to turn our attention to some of the greater highlights. We won't spend much time on PREM today, but we do want to say thank you again to Team Birth for their engagement and support with the patient-reported experience measure. As far as the process measures, we also asked that we had teams look at whether or not their faculty and staff were being trained in implicit bias. We also asked that we look at 2 important areas: hypertension and hemorrhage. The process measures for hypertension included timely treatment within an hour, and the process measures for hemorrhage looked at whether or not we were giving risk levels assigned to patients for risk of hemorrhage. And then did we also look to see that blood loss was measured in a quantitative and cumulative way. So let's take a look and see how we did over this course of this year. And I think you'll all be really pleasantly not even surprised. I think you'll be pleasantly pleased at what we're going to hear today. So in order to achieve maternal equity, there are a few things, 6 in particular that many of us, Deborah Bingham, Dr. Jopp, others, we wrote about this a little bit to talk about what are some of those major steps toward achieving maternal equity. When we think about those hospital teams that have achieved maternal equity, we brought one of them to our summit when we brought Christina Davidson to talk about what was happening in Texas in achieving maternal equity. One of the first that we noticed is that related to governance. Then we'll go into data collection, clinician education, community engagement, and best practices. But let's go to the next slide and we'll show you what we mean about governance and how we've done with forming equity teams. As you can see from September, these slides that you'll see go from September 2022 across from left to right to August of 2023. That is our 12 months of our equity bundle. And we also see from 0 to 100%. So from on your y-axis, the percentage of teams. Now, this is a result of all the teams that submitted. So not all of these teams consistently submitted across the entire time, but it's important just to see the raw information of all the teams participating. Overall, we saw a positive trend toward creating governance, having an equity committee to think about and talk about and address what are those issues of inequities. We focus in on the inequity, and we talked about this as we launched this bundle. We focus in on the inequity related to race. That being said, there are inequities related to all the demographic and the demographic identifiers. Not every hospital experiences them, but you may see differences related to race, ethnicity, language, geography, ability, sexual orientation, and gender identity. And so with that information, it's important for us to be able to have governance, to think about what we're doing to raise our standards. So no longer just looking at our data for the total population, but raising the standard to say we're going to have governance to think about what are the outcomes for all of our populations, which populations are having outcomes that we can improve upon, and how do we take those steps toward that using a QI approach, setting an aim statement, creating a driver diagram, and getting those change concepts, and then working towards that, as well communicating. That's what your governance can do, to communicate those goals. It's a really important point to show and see that across Massachusetts, we've increased our governance at the hospitals on our L&D units to deal with equity for maternal health. Let's go to the next slide. This shows our formal equity teams based on obstetrics among those 7 hospitals that submitted every month. And so we can see here, even if you just look at the hospitals that submitted regularly, there is that increase. And that increase came pretty steeply across the fall into the spring. And we're really excited about that. All right, let's go to the next slide. When we think about the diversity of our equity teams and we look at the types of roles, whether or not a person is in quality, a nurse, a physician, et cetera, and not having an equity team that's just a small subset of clinicians, but really looks at all of those faculty and staff within your hospital system that play a role in improving these outcomes. That cute little 2 there just represents the fact that 2 hospitals have told us that they have a community member and that they've been able to successfully engage a community member on their equity team. So their diversity of roles is greater in the sense that they've been able to bring not only clinicians, and then for some of the hospital teams, clinicians, social workers, quality leads, as well as community members onto their equity teams to have these conversations. So I want to say congratulations to those 2 hospitals that have been able to accomplish that. It's really inspiring. And again, here, as you can see, an upward trend in the diversity of roles. Let's go to the next slide. Among those 7 hospitals that reported consistently, same, an increase in an upward trend of diversity among roles. All right, next slide. Now, we also asked around a question about your goals, setting a SMART goal or SMARTY goal in your aim statement, and wanted to look at where teams stood. And so this is the aggregate of all the teams that submitted. And what we see is few teams, as you can see at the height, 4 teams had in place obstetric equity goals that have been communicated to their hospital teams and their groups. And that's something that in order to move forward in our equity work, in order to move forward in any quality improvement work, having that goal, the aim statement created and set, and having everyone know what we're working towards, what our vision toward forward motion is, becomes really important. So I think this shows us an area of opportunity for many of us. Actually, in doing these slides and thinking about our own equity committee here at UCSD, I also realized that, we have an anti-racism statement and we have set some goals. And our anti-racism statement does identify what our goals are and what our values are, but not necessarily what our goals are in the short and long term in such a way that everyone understands what we're all working towards. So we're moving in a different direction to make this possible. And so I want to say that I want to just honor the fact that this is not a very straightforward and easy task, but one that becomes really important if we're going to move our equity work forward. All right, let's go to our next slide. And when we think about our change concepts, even fewer had change concepts that they had in place that they wanted to communicate to their teams. Okay, let's go to the next slide. I'm going to pause for a moment and just check the chat and see if there are any questions, thinking about how we're moving towards governance in Massachusetts. So the take-home message there is we have increased our governance, our infrastructure in order to do equity work so that we can move away from equity feeling like it's the large and amorphous and difficult task to tackle, to now having a group of individuals on our L&D units with our own data, with our own experiences, with our own local politics, to sit and think about what we can do to make sure that all populations experience great outcomes and great experiences. I'm looking for any hand raises, any questions related to governance or comments that anyone would like to make at this point. All right, great. And if you just joined, please don't hesitate to put your name and your institution to the chat so we can collect that for our attendance. All right, we're going to move into talking about data. If there's anything that we really wanted to make sure comes out of your experience in working with this bundle, it was the collection, the ability to collect, to disaggregate, and to monitor your data. And we knew and found from many of the respondents, most respondents were already collecting data by race, ethnicity, and language. If you go to the next slide, we'll see that all teams were, yet not, I'm sorry, not all teams, but many teams were, not to the degree of race, ethnicity, and language. We're collecting information on ability, gender identity, and sexual orientation. But we do also see across the time an upward trend there as well. That is probably in conjunction with a few activities that were happening across the state, across certain health systems. I know the MGB health system and UMass health system were already working on collecting that data and those identifiers. Let's go to the next slide. And we did see that most often that the gold standard, the way we understand this information, is to have it self-reported, that we don't want to assign race, ethnicity, and language to a person registering on L&D to give birth. And I make that statement very purposefully because there are healthcare systems that have looked at and toyed with and tried and done pilot projects around how do we assign this information, because they want to make sure that they have this information in the chart so that they can look at data by race, ethnicity, particularly when communities aren't reporting and aren't self-reporting, which says something about the trust for that healthcare system. If you have communities of people that are coming to receive care in a hospital system, but feel shy and uneasy around reporting their race, ethnicity, and language to the healthcare system. All right, let's go to the next slide. So self-report also, we know that is important, and it's the gold standard. And then once we are there, the important next step is to use that data in every clinical processes. So whether we're looking at, for instance, in this bundle, timely treatment of hypertension, quantitative blood loss use, whether you're looking at your breastfeeding outcomes for baby-friendly measures, or whatever your other QIPs are, your quality improvement processes that you have to submit to any of the QI agencies, we want people to walk away from this bundle having begun the process of practicing and being purposeful about stratifying data by race, ethnicity, and language, because it's not enough anymore to keep the older standards of looking at our total population. We want to raise the standard to start looking at the varying populations. And it's important to raise our standards in healthcare and within maternal health because of the fact that we see these rising rates, these rising trends. We cannot keep doing the same thing and expect a different outcome. And this is the forward step that we see has made a big difference in many other institutions. For instance, Christina Davidson talked about in Texas how just looking at their data, they started to see a trend increase. Part of looking at the data means correcting the data. It could be that there may not be disparities there when you actually have the data appropriately assigned and documented. The important part of this slide is that you'll also see, once again, a trend increase from September to August. So you see in the left end of the slide deck, race stratification, a trend increase. You'll see ethnicity in the center, there was a trend increase. And then for language, lower utilization, but again, a trend increase. All right, let's go to the next slide. And we see here among those hospitals that submitted consistently, this is again, race, ethnicity, and language. We also see a trend increase, pretty much doubled from 2 hospitals to 4 hospitals for race stratification, ethnicity stratification. And that becomes very important in how we operate on our L&Ds. Let's go to our next slide. So I'll pause. I'm just checking the chat and I'm looking for any raised hands. If anyone has any questions, comments, or feedback on our push toward helping teams collect, disaggregate, and monitor data. All right, great. And if you're just coming on, please put your name and your institution to the chat for our attendance, and let's move into clinician education. So let's move over to our process measures. What are the next slide? So thank you, and thank you to Institute for Perinatal Quality Improvement, to Dr. Jop and the Mass Department of Public Health, to everyone who has helped make it possible to speak up against racism, was allowed to be taught across our state from March 2020 into now what's going to be this Thursday, October 18th, right? That's the right day. Yeah, Thursday, October 18th. In Springfield at the Massachusetts AWON conference, where we'll also be teaching Speak Up again, but this will be the second time we're doing it in person. Yes, sorry, Kaylee, the 19th. I'm getting my dates wrong. Sorry, forgive me. It'll be Thursday, October 19th in Springfield at the MGM where the Mass AWON conference is being hosted. We'll be teaching Speak Up again there. And with that, we see that we've had a trend increase again across September to August of those clinicians being trained in implicit bias, racism, and racial disparities to understand these differences and understand the disparities and equities that we're finding. It's wonderful to see this. And we go to the next slide. You'll see that we started to look at the data a little bit more in depth here, where we asked the question around those hospitals that were submitting consistently. And so we see there's a higher percentage into the 90s now rather than the 80s of hospitals that are reporting clinicians trained. And we'll go to the next slide. And the question, this does beg the question, who's in that 10% and how can we get there to having 100%? But we did ask the question, is there a difference between higher volume hospitals and lower volume hospitals? And not a difference in terms of capability, but a difference in terms of what we might find because of resources, resource allocation, We also think about NICUs, and we know that when it comes to thinking about improved outcomes for babies, often we see that in high volume NICUs. And we were curious if we had the same findings in high volume obstetrical units. And so what we see in hospitals that deliver less than 1,500, higher percentage of trained clinicians, and always, as you see the lighter blue bar, always the nursing staff were more frequently trained, or the greater percentage of trained versus the MD staff. You go to the next slide. Among the hospitals where we have a proportion of those that were among the hospitals for 1,500 or more deliveries. Sorry, I'm just going to take a pause for a second. There it is. We also see that it's a slightly lower percentage, but more in keeping with that larger overall first tally 2 slides back, where we saw somewhere in the 80s. But here you don't see necessarily the trend increase. You see a sort of a variation. It's variable depending on the months as to what percentages were trained. We do have within Massachusetts requirements from the Mass Med Board for training for implicit bias. Many hospitals have put that rule in place as well. And in the state of California, we have a law that all perinatal care providers and those working on perinatal care units also have to have this type of training every 2 years. So I want to say congratulations to the teams, and thank you again to IPQI for providing that education. All right, we'll go to the next slide. So let's talk about implementing best practices. So we've talked about governance. We have our equity teams. We've seen a trend increase there. We've seen how teams have begun to collect, or begun, more teams are collecting, disaggregating, and monitoring their data. We've also talked about clinician education, how we're educating more clinicians across Massachusetts, and how 2 hospitals have begun community engagement, and PennQuin is set upon supporting community engagement across the hospital teams, as we now have new funding and are seeking, and you'll hear more about this from Kaylee at the very end, seeking to hire a lead to support community engagement in a PFAC, a Patient Family Advisory Committee for PennQuin. Let's talk about implementing these best practices. The 2 in particular, we'll go to the next slide. The 2 in particular are that related to hypertension and hemorrhage. So we talked about timely treatment of hypertension. There's a few other questions we ask around hypertension. And then there is quantitative blood loss and hemorrhage risk assessment. So let's talk about hypertension. Here we ask the question of the proportion of birthing people with severe hypertension that were treated within 1 hour with the appropriate medication. And we actually do, over time, for all submitting hospitals, see a trend increase. Now, there are a few moments where we have dips in January and February, and then in June where we see actually a pretty sizable difference between that group, which is probably a significant disparity. However, in July and August, we definitely see that there aren't differences there, and around 70% of the time. There are questions that we can all ask and start to answer around the timely treatment. When we don't see 100%, it doesn't necessarily mean that patients weren't offered or that it wasn't available, but it does indicate places where we can ask questions in our own units and start to understand, are people declining medication, or medications not available? Are we able to support nursing staff to be able to provide these medications? Are orders being placed in an easy enough and expedient and efficient enough method for that to be available? So lots of questions that we can ask and answer, because the goal would be is that we're as high as possible among those who have been offered timely treatment and those who would agree to accept timely treatment of severe hypertension. All right, let's look at the next slide, because here we go into those treated within 1 hour among the hospitals that submitted consistently. And we do see where we've had a trend increase here. And so really wonderful to see that we've had, 90% some odd that were treated in July and August. And then when we look at the next slide, we'll start to break that out a bit by smaller hospitals. And here at the smaller hospitals, you see that there are fewer births to non-Hispanic Black women, and smaller numbers if you look at the chart to the right of the number of people, because when we do the QI work, this is chart review. And so we're pulling a percentage of the charts based on a percentage of our number of total births. And we can see where a lot of times in the smaller hospitals, you'll have timely treatment happening pretty often. But let's go to the next slide where we have the greater than 1,500 deliveries. And it's lower, it's actually less, greater numbers of people, but less often the case. I think that raises questions that we could start to answer as a team, as a collaborative, to understand and think about what that means, that we have a fewer percentage of those presenting with severe hypertension that are treated with 1 hour if they're in the higher volume hospitals. I'm going to pause there for a moment and just welcome those who've just joined and ask if you've just joined to put your name and your institution into the chat so we can collect your name and your information for attendance. We gave some kudos and awards earlier to those who attended 50% or more. And then also, we're going to talk a little bit more about what this means, but I'm pausing to look in the chat to see if there are questions related to anything we're seeing with the data related to severe hypertension and the treatment there. No worries, Dr. Ramos. Welcome, welcome everybody. Any thoughts, any questions, any hand raises? Let's go to the next slide. Here's something I do find interesting. The proportion of birthing people with severe hypertension who receive preeclampsia education at discharge. I am actually very curious what others think, if others want to put their information or thoughts in the chart. In the chat, not the chart. What is it that would prevent us from having 100% on this particular measure? A1 has provided us with post-birth warning signs. Many hospital systems have it automatically set up to provide this information and the discharge summaries when severe hypertension has been experienced or preeclampsia. Can anybody say more about why we think this wouldn't be 100%? And should we expect 100%?
Audra, it's Kristen Price.
Yeah,
I'm just wondering, since it's part of the discharge summaries, usually, is it just that, or is that the case for everybody? So could some of this just be that they weren't able to find the documentation in the EHR, that it was given to the patient, but that there's just no way of confirming that when they go to do chart review?
Yeah, I think that's a really good comment. I was wondering, Kaylee and I had a long conversation, and Caroline and Brianna, as we were looking at the data and thinking some similar things. Is it that it's there and it happened, but it doesn't get recorded? Leslie also wrote, many systems still rely on the individual providers to place the available discharge info into the discharge summary. So it could be on the provider side that we're not putting that information there. Maybe there could be a very simple EHR solution to these things. I know Ron Iverson's team at BMC has often used the EHR for some really nifty and neat ways to close gaps. Allison also said it's included in our discharge teaching folder. So that's where they may have it. So it varies. I think this is one of those spaces and places where when we talk about the data, many of us know that the 52% is that number that we hear of where the maternal deaths are happening after their experience on LND. And that's in that postpartum phase. And we've been using this phrase, falling off a cliff when it comes to postpartum. But with that being said, this is one of those measures, and maybe I can ask people to do maybe like a thumbs up if they would agree on the reactions at the bottom of your Zoom screen. Do you think this is one where we should be at 100%, and that at 100% would really give a lot of confidence to birthing individuals that, wow, if I go to this hospital, they're going to make sure I walk out with all the information that I need? Because we know people are getting information also from doulas. We know people are getting information from their healthcare teams, but it would be great to be able to capture that, say it, and show it. Curious what others think. I see a couple of thumbs ups. Any other thumbs ups that this would be something that, this is what I'm thinking, but I'm curious what the overall group is. And Dr. Ramos suggested, he wondered if we could consider giving discharge information on day prior to discharge so patients have a chance to review it and ask questions. Wow. What a concept. That is fantastic. That's a really great thought. These are some things that we could start to move toward to really utilize being where people are, because they're with us, they're on LND, they're in postpartum, and before they go home, we have very straightforward and wonderful and easy to read and easy to understand post-birth warning signs. A1 has done a great job with that. I want to say, I don't know that ACOG has done a great job with that in terms of like, these are the sorts of resources to post. So I don't recall seeing that. But with that being said, I wonder if this is something we could hit 100%. And I think that could be a goal. All right, let's go to the next slide. Here we look at the proportion of charts of birthing people with severe hypertension who are scheduled for a 72-hour blood pressure check. I mean, just from my own experience, I understand why this doesn't hit 100% in the sense of it's probably hard to get that scheduled and get that captured. That is an administrative task of a best practice. That's something that I think most hospitals and many of us would also love to see this go up to 100%. We'd love to know that there is a catchment, right? This is the question around a safety net. Do we have a safety net for those who are leaving the hospital with severe hypertension to ensure? And so if we're saying 60, 70% of the time we're seeing it there, we're only about 60 or 70% of the time being a safety net. Who's in that delta? Who's in that 30%? And why does it exist? What can we do to overcome that? There are so many programs that are happening to help connect patients with severe hypertension or symptoms or concerns back to their healthcare providers and hospital systems. How can we really start to utilize that across the state of Massachusetts? So this also is something that's at 100%. We also have our own home blood pressure monitoring programs that are going on as QI projects right now related to Penquin. And we have the UMass is part of that, and BMC is part of that, and Brigham and Women's has a program happening. This is something that we'd really love to see those numbers as high as possible, because this is around safety nets. How are we making sure that patients leaving the hospital who've had an episode of severe hypertension or are at risk for worsening blood pressure have a check and have follow-up? Any thoughts or comments there on this particular? Does this one, any of this around the severe hypertension measures surprise anyone? Or do we feel like this feels like what we see and unsurprised? I'm just looking at the chat. I don't see any comments for the moment. Oh, Dr. Ramos came off mute. Let's see. What are your thoughts, Dr. Ramos?
I think what comes to mind sometimes is, those discharges on a Thursday or, over the weekend or a holiday. That's really when we find that 72 hours gets stretched to a week, or, especially because with a holiday weekend, all those scheduled Tuesday, Wednesday appointments are booked. So, I think in terms of, I think this should be an expectation. And a lot of times triage is sort of used as the, weekends and nights, but we should, right, be able to use it. Although there's quite a bit of pushback, and I know there's a lot of resource heaviness there, but a blood pressure check certainly, is something that we should be able to accommodate. But I have to say that I still haven't found a way to do that, smoothly over the weekends. But it's something that we can look into and see if it's a lot more about just finding the resources or having, the ability to have a room just to check up blood pressure, have the resident. But I think that's when we find the hardest issues in being able to get that 72-hour check.
That's a really great comment. Does anyone otherwise have a system that they use within their hospital system over the weekends to ensure that they're catching these patients that are leaving? And to say to your comment, Dr. Ramos, when I was at Brigham and Women's, using triage was something as well, frequently utilized. And it's different to work at a hospital where postpartum does not come to triage. Our postpartum patients either go to urgent care or the emergency department. And so that changes the game as well. So across America, having those systems set up are difficult, which is why I think this rise of innovation and systems in place so that blood pressure is captured through these tech options and brought back into the healthcare system and then monitored in a very specific way become really important. And I'm curious who's got a really well-working system that they want to talk about that, they're noticing weekends don't become a problem. Yeah. Krista said VNA is a great resource if they can get them scheduled. That's true too. Yeah. Listen, guys, we're in the age of AI and tech. At this point, we should be able to use some of these things to make sure that we have safety nets in place for people so that no one's at home, possibly at stroke range, and not able to get information care or medication titration from a provider. So what we can do to get there becomes really important for making sure we start to turn that curve that's still heading in the wrong direction for increasing and elevating rates of maternal morbidity. All right, let's go to the next slide. We're going to talk, I think, now about hemorrhage. All right, let's go into the next best practice around hemorrhage. Here is something and I really like this slide because here's an example of how we can do it. When we think about giving someone a risk assessment for hemorrhage and EHR works well to do that, look at these numbers. They are just nearly 100%. And I think that, of course, there's going to be a patient or two that comes in that delivered right when they were rolling in. And so they get part of your, they might be part of your chart review, and that might be the one person that actually didn't have a hemorrhage risk assessment. So there can be reasons why 100% isn't the case, but this 90 to 99 makes sense. What are your thoughts? Any particular responses or reactions to this? This shows that there are things we do in our hospital where we're hitting 100% as we would be expected to for best practices. And as you're thinking of any comments you might have, let's go to the next slide. I just want to show how we do when you're looking at hemorrhage risk assessment for the hospitals with smaller volumes of birth. So 100% of the time, if you're delivering less than 1,500 in the state of Massachusetts. When you go to the next slide, or among these 17 hospitals out of the 40, we see that for those with the higher volume, again, very high, 90s, 98%. And so what's different? I guess that'd be interesting to find out, what's different between the smaller volume hospitals and the larger volume hospitals that they're hitting 100%. Okay, so there's one or two people are getting their risk assessments documented. All right, let's go to the next slide and take a look at really what's important around this issue of estimated blood loss. So the proportion of measurement of blood loss, so QBL, quantitative blood measurement, whether that's through gravimetric weighing, whether it's through volumetric, or whether it's through those photometric techniques where they're using tech and AI, how are we doing? And we have seen a good percentage. When we did the hemorrhage bundle, we saw ourselves go from somewhere consistently in the 60% to now 80s. And so we see that 80s to 90s across all participating hospitals. So this is an area where I think obstetric hemorrhage, we've all tended to take that deep dive, definitely related to accreditation. Joint Commission requires many of these metrics to be reported upon. When we look at the next slide, let's look at the larger and smaller volume hospitals. So among those hospitals that consistently submitted data, we did see an overall trend increase from those 80s up to the 90s and to the mid 80s, higher 80s or 90s. So thank you to that. But when we look at the smaller volume hospitals, we see it more often, 100%, 93%, 96%. And then let's go to the larger volume hospitals on the next slide. Here we see it a little bit less utilization of QBL. And there's a huge delta and a gap as to why that may be happening. So QBL, for some hospitals, they're doing it with C-sections, but not doing it with their vaginal births. Some are saying they reserve the space to do that when the vaginal birth becomes complicated, but many may argue doing it with all vaginal births allows everybody to be practiced and purposeful with the whole concept of high volume hospitals being able to do something so often, so frequently, that you've worked out all of the kinks of a process and that it's pretty smooth. So let's go to the next slide. I think that might be the wrap up of our data. So overall, we saw trend increases in having an equity team, 2 teams with a community member. We've seen an increase in teams commenting on having change concepts, SMART goals, and SMART aims. We could do better here as well, so we can guide our teams forward, particularly around those issues around severe hypertension. When you go to the next slide, also as a summary, we see that we're starting to stratify more our data by race, ethnicity, and language, though language to a lower extent, but we're hitting 100% on self-report, which becomes really important and not the case at a lot of hospitals in a lot of other states. Okay, we'll go to the next slide. And I think it just wraps us up. So we are working to achieve maternal equity. I think our bundle has shown us that a round of applause that Kaylee had on the earlier slides is really necessary because many of you take your time and efforts and have moved them forward to submitting data. We know that it's a heavy lift to have this administrative task, but what we've been able to see is that across the state, we're doing better with our governance, our data collection, disaggregation, and monitoring, educating our clinicians and implementing these best practices. we're working to improve our community engagement. I think we'll see more of that in the future. But that being said, I just want to say a whole very large volume, wholehearted thank you to everyone who's participated and to those who submitted their data. It's just been, as Kristen said, it is amazing to see the work and what has happened over these 12 months. And thank you to the Penquin team for all the work to make sure that these webinars are happening. We'll talk more about this at our Equity Summit, and you'll hear more about what we're doing across the state to address health equity, particularly the maternal dyad. So not just thinking maternal health equity as we're looking at here, but what's happening in our pediatric and our neonatal spaces as well. So we go to the next slide. I think we're going to end up turning it over to Kaylee to give some more congratulations as well. I want to say thank you also to the Betsy Lehman Center, because that's where our data is coming from. You're submitting there. We are very, very lucky. We would not have our PQC if it weren't having our data center, the Betsy Lehman Center. And so I want to say thank you so much to Barbara Fain for your leadership and Julia Prentice for your leadership, and then all of the team members there who also work to make sure that we have data to bring back to you. I'll stop talking for a moment. I'm just checking the chat right now to see if we have questions. And please, if anyone wants to raise their hands or come off mute to ask a question related to what they saw, don't hesitate to do so. Thank you so much to Team Birth, for Ariadne Labs, to Lindsay, Misha, Amber, Jonathan, and Tyler for all of the work to help our teams with looking at patient report experience measures. Right now, we're still taking a deep dive into looking at what's happening with outcomes. Just as important as the outcomes are patients' experiences. And so I know that a lot of teams are working on that and working on shared decision-making and implementing Team Birth and the whiteboards to engage patients as part of their own teams. And so I really appreciate seeing these culture shifts in that direction. It's been fantastic. All right, I am checking the chat for questions and I will pause. I'm just curious of any reactions, though, even if it's in the chat or just, not to ask a question or make, a really witty comment, but just curious. Well, thank you, Dr. Ramos. Just curious what folks think about any of the data. What data may have surprised you? What data seemed to be something that motivated you now to move forward in your own institution? All right, I'm going to pause. I'll turn it over to you, Kaylee. I'm not sure we have any questions right now, but thank you everyone for listening and for participating.
Awesome. Thank you, Audra. And I know we did have some folks who joined late, so just want to say again that this webinar is being recorded. They're always available on our website. So if you missed the first half of today's presentation, the recording will be available in a few days, so you can go back and check that out. So we have several announcements for you today. One of the biggest ones is regarding future bundle implementation. So we've been talking about year 2 of the equity bundle, year 2 of the bundle. So this current version that we currently do with data collection and monthly webinars will continue between now and June 2024. And at that point, at the Penquin Spring Summit, we will kind of formally wrap up this bundle in its current version, but then we will be transitioning to implementing the perinatal mental health conditions bundle with an equity lens. So a lot of the components you've seen from the equity bundle in terms of having an equity team, an aim statement, data stratification and collection by race, ethnicity, a lot of those elements are going to carry over to the mental health bundle. So you will already be prepared. So that bundle will be launching in fall 2024, probably September, but we'll begin to onboard hospitals for that work starting in July, because we know with summer vacations, people are here and there. So we wanted to give a little bit of time in the summer to start that process. So more details to come. Until then, we have equity bundle webinars every month, except months that we have summits. So you're here with us today in October. We'll be hearing from Bay State Franklin in November. And then we will skip December because we hope all of you will come to the Penguin Summit in Norwood instead. Then we'll pick up back in January through May. And then we'll have the summit again in June. And then we will have a team presentation from Tufts in July. And thank you to the Tufts team and Martha's Vineyard and Bay State Franklin for volunteering to give presentations on our webinars. We do have these dates remaining. We are hoping that this year's webinars will be hospital team led. And again, we want to reiterate, we've come so far in this last year, but we know this work is not over, and many of you are still in the thick of it, or you're still, jumping over hurdles to get a project started. You don't have to have a complete project or even any, evidence of success to present on a webinar. Instead, you can come, you can share your challenges with the group, you can ask questions of the group, seek resources and just get feedback. We really want these, we call them presentations, but they're just opportunities for you all to kind of bounce ideas off this wonderful collaborative of hospitals across the state. So we encourage you to use that time however would be most productive for you, and everyone else will learn in the process. Just a friendly reminder that the Penguin website is live. You can explore it here using this QR code. We are still continually uploading resources and just making navigation of the website cleaner and easier. So thanks for your patience if anything isn't where it is supposed to be quite yet. For those who may be new to the Equity Bundle or would like a reminder, we do have 2 toolkits, the Equity Bundle Toolkit and then a more general quality improvement toolkit on our website, as well as a respectful care commitments poster that we co-created with Ariadne Labs. So these are 2 great resources to continue the journey on this bundle. Then I already mentioned the summits, but just want to reiterate our fall 2023 summit is on Monday, December 11th, starting at 8 a.m. In Norwood, the 4 Points Sheraton Hotel in Norwood. We're excited to welcome keynote speakers, Dr. Robert Goldstein, our new Massachusetts DPH Commissioner. Tiffany Moore-Simus will be speaking to maternal mental health. Cindy Liu will speak to mental health in the NICU, and then we have Thea James coming to give an overall presentation on equity, so kind of tying equity and mental health together. And then in the afternoon, we typically do breakouts, but this time we're doing a format where everybody will hear all of the afternoon presentations in the same room. So we're excited to bring to you some updates on the Equity Bundle, as well as our neonatal equity project on social determinants of health screening. You'll hear about levels of maternal care, remote blood pressure monitoring, which, as Dr. Meadows said, could be a solution to increasing those rates of postpartum blood pressure checks, as well as updates from the Perinatal Opioid Project on toxicology screening for breastfeeding with OUD. So we're really excited for this event and hope you all can come. Friendly reminder that, again, all these webinars are recorded and they're available for you to claim continuing ed credit until early December, until December 3rd. We circulated this job posting last time, but BMC is seeking a part-time nurse to help manage the remote blood pressure monitoring program. So can read more and apply at the QR code here. And Caroline's also posting links in the chat. We've got lots of job postings today. So Dr. Meadows also said previously that Penguin is seeking positions for co-chairs. We are looking for an obstetric registered nurse co-chair, and then 2 co-chairs on the neonatal side, 1 MD and 1 RN or CNM to help us lead and guide Penguin. These slides will be posted along with the recording. I'm also going to be sending out information on the job postings via email. We're so excited to grow our team and have these new co-chairs kind of lead us into the future for Penguin. As well, we're also looking for our PFAC engagement coordinator. So this is a part-time role, approximately 40 hours per month. If you know somebody who is experienced or passionate about engaging patients and families and would like to lend their experience to the Penguin team, we would love for them to apply. And all job postings, you can send application materials to Caroline, and her email is on the slide and will also be in our follow-up emails. I'm almost there, just a few more events. You all know our wonderful partners at the Institute for Perinatal Quality Improvement. They have a webinar coming up on November 30th on promoting neonatal equity and justice. This is typically a maternal group, but we love to support our colleagues on the neonatal side. And as we know, moms and babies are a package deal, especially in those early days. So if you have interests or have colleagues who are interested in learning from this webinar, we encourage you to attend. As well as we have a couple Speak Up opportunities coming up. So for those of you who have taken Speak Up Champions training, there is a free ambassador training happening virtually on December 1st from 8:30 to 2:30. You can register for free using this code, and this is a continuation of the Speak Up course and just is an opportunity for you to strengthen your knowledge and your leadership skills around implicit and explicit bias. And I think this is my last slide. Again, if you have taken Speak Up Champion training, the course faculty are doing an evaluation and would find it really, really helpful for you to complete their survey so you can let them know your experience taking the course. And they are offering thank you to participants in the survey. You can receive the Speak Up educational modules for free or a discount on the Ambassador Conference. That's not really applicable to Massachusetts because you all can go to the Ambassador Conference for free anyway, but do scoop up those modules because they are a wonderful resource. Okay, I know that was a lot. Thank you all for sticking with me. I'll be sending out all that information in my follow-up email. And thank you all again for your participation and for joining us every month. And we're excited to see you on November 21st at our next webinar.